Hello, everyone. Today I'll be presenting on Schedule to Controlled Substances, specifically focusing on stimulants and opioids. As future nurse practitioners, understanding how to safely prescribe these medications while preventing abuse is critical to our practice. This presentation will last approximately 10 minutes, during which I will discuss the challenges we face in caring for patients who require these medications. What are Schedule 2 controlled substances? Schedule 2 controlled substances are medications classified by the DEA as having a high potential for abuse, but they also have accepted medical uses. What makes them Schedule 2 specifically is that they can lead to severe psychological and physical dependence. Unlike Schedule 3 to 4 medications, Schedule 2 drugs cannot be refilled. Each prescription requires a new written order. Today, we will focus on two major categories: stimulants, primarily used for ADHD, and opioids used for pain management. Both present unique challenges for prescribers. Schedule 2 stimulants, clinical uses. Let's start with stimulants. According to Eland and Gildon's 2024 research, stimulants are the first-line pharmacological treatment for ADHD due to their strong evidence base. The prevalence of ADHD is significant. Nearly 10% of children have been diagnosed. There are two main classes: methylphenidate-based medications like Ritalin and Concerta, and amphetamine-based medications like Adderall and Vyvanse. These medications work by blocking the reuptake of dopamine and norepinephrine, helping patients with ADHD improve their attention and reduce hyperactivity, impulsivity symptoms. Challenges in prescribing stimulants. Prescribing stimulants comes with several significant challenges. First, there is substantial risk of misuse, abuse, and diversion. The FDA updated its box warning in 2023 specifically to address this issue. As prescribers, we must assess each patient's risk profile before initiating treatment and continue to monitor them throughout therapy. We also need to carefully monitor cardiovascular parameters, blood pressure, and heart rate at baseline and every 3 to 6 months, as these medications can cause hypertension and tachycardia. Growth suppression is another concern in children, requiring regular monitoring of height, weight, and BMI. Finally, recent drug shortages have complicated care, requiring us to understand alternative formulations and how to safely switch patients between medications. Schedule 2 opioids, clinical uses. Now let's turn to opioids. These medications are primarily used for pain management. While they are highly effective for acute pain when properly managed, there is actually limited evidence supporting their use for chronic non-cancer pain. Common Schedule 2 opioids include oxycodone, hydrocodone, morphine, and fentanyl. Despite increased attention to the opioid crisis and efforts to reduce prescribing, prescription opioids still account for approximately 30% of opioid-related overdose deaths. This statistic from the CDC data through 2019 underscores why we must be extremely careful in our prescribing practices. Racial/ethnic disparities in opioid prescribing. Research by Flores and colleagues in 2024 revealed significant racial and ethnic disparities in opioid prescribing. A study of over 22,000 patients in an urban safety net healthcare system found that white patients received more opioid prescriptions overall and were more likely to be in the highest prescribing category. They also had a greater risk of developing opioid use disorder after receiving prescriptions. Conversely, Black, Latina, and Asian patients received fewer prescriptions and were less likely to receive follow-up pain medications. This raises a critical ethical question we must grapple with. Does this represent inadequate pain treatment for minority patients due to provider bias, or does it reflect a protective effect against opioid dependence? The answer is likely both. We are simultaneously undertreating pain in some populations while overtreating it in others. Opioid prescribing presents complex challenges. First, we must balance effective pain relief with addiction risk. And unfortunately, we don't have reliable tools to predict which patients will develop opioid use disorder. This is particularly challenging for chronic pain patients who may need ongoing treatment. Second, we must be aware of our own potential biases. Research shows that providers often make different prescribing decisions based on patients' race and ethnicity, sometimes undertreating pain in minority patients due to concerns about misuse. Third, we face increasing regulatory requirements, including prescription monitoring programs and state-mandated prescribing limits. Finally, we are dealing with an evolving overdose crisis. While prescription opioid deaths are declining, overall opioid deaths continue to rise due to illicit fentanyl, and we know that prescription opioids can serve as a gateway to illicit use. Strategies for safe prescribing. So, how do we prescribe these medications safely? First, comprehensive risk assessment is essential. Before prescribing any Schedule II controlled substances, we should screen for substance use history, assess for mental health comorbidities, and use validated screening tools. Second, ongoing monitoring is crucial. This includes regular follow-up appointments, appropriate urine drug screening, and checking prescription drug monitoring programs. Third, para-patient education is vital. We must discuss risks and benefits, teach safe storage and disposal, and educate patients about signs of misuse or addiction. Ultimately, we should always consider alternative options for ADHD. Behavioral therapy should be offered alongside or before medication, especially in young children. For pain management, we should utilize non-opioid analgesics and multimodal approaches. The goal is to provide effective treatment while minimizing risks. Our role as nurse practitioners. In conclusion, Schedule II controlled substances, both stimulants and opioids, are powerful therapeutic tools, but they require careful, thoughtful use. As nurse practitioners, we have a responsibility to remain vigilant in preventing abuse while ensuring that patients who need these medications receive adequate treatment. We must be aware of our own potential biases and strive to provide culturally competent, equitable care. This means treating pain adequately in all populations while also appropriately monitoring for the risk of misuse. It also means staying current with prescribing guidelines and continuing education. Ultimately, our role is to protect our patients from harm while providing them with evidence-based treatment. We must advocate for our patients and ensure they receive the care they need, no more, no less. The balance is delicate, but with knowledge, awareness, and ongoing vigilance, we can prescribe this medication safely and effectively. References. Here are the references I used for this presentation. The primary sources are the Eland and Gildon article on ADHD treatment, the Flores study on racial disparities in opioid prescribing, and FDA safety communications. Thank you for your attention. I am happy to answer any questions you may have. Have a wonderful day.